So, good evening, everyone. Good evening, everyone. I'm Dr. Margaret Falk from Hong Kong. I'm the APOA Hand Upper Limb Society Chairman. Today, we'd like to welcome you all to join the APOA Hand Upper Limb webinar, which is the second webinar of 2025. This is Hand Upper Limb Society is part of the APOA Society, of which we have established in 2020 June. And so the aim is to promote professional education, research, and other common interests in hand and upper limb surgeries. We have done regular webinars as well as master classes. And today, the webinars on hand and upper limb is going to be focusing on upper limb instability. And that will be done for both the shoulder, the elbow, as well as the hand, which is the PIP joint. So we have included a wide variety of experts to come and give us lectures, as well as our committee members to give us the comments and moderate the sessions. So without further ado, let's start with the shoulder. And I would like to invite our moderator, Dr. Jana Tumpalan from Philippines, to introduce the speakers.
Thank you, Dr. Falk. Good evening, everyone. And it's my pleasure to moderate the shoulder session to kick things off. We will highlight both anterior and posterior shoulder instability, featuring two excellent talks from our Asia-Pacific experts. And we also have our distinguished commentator, Professor Myung-Sun Kim from South Korea, who will share his insights after both lectures. Our first speaker is Professor Atsushi Tasaki. He will be talking about the Bristow procedure.
I'm sorry, I can't hear you. I can't hear you.
Jana, I think you are muted now. Yeah.
Yes. Yeah. I don't think the.
Can I start now?
Yes. Yes, Prof. Sorry, your slides are not coming on, I think.
It's okay. Can I start?
Yes, over to you, Prof. Thank you. Yes, Prof.
Yep. Thank you very much for having me in this international meeting. I will talk about the arthroscopic bunk-out repair and open Bristow procedure in collision athlete. One of the main contributors to shoulder instability is damage to capsular labrum complex as a bunk-out lesion. This lesion also plays a role in joint proprioception and may result in degenerative osteoarthritis. Body structural damage such as bony bunk-out lesion or Hill-Sachs lesion also significantly compromise joint stability. In collision athlete, these bony lesions are particularly common. If absorbed, they create a bone defect that contribute to recurrent dislocations and negatively affect the shoulder kinematics. Surgically, arthroscopic soft tissue and bony bunk-out repair are essential for stability, and coracoid transfer serves as a reinforcement. In order to re-establish the critical biomechanical concepts, such as the circle stability concept, vacuum effect, and the balance of the slack and tension with torque. However, recurrence is not uncommon. In contrast, coracoid transfer provides a sling effect via the conjoint tendon. This procedure can be recognized tendon transfer surgery, not bone block. When combined these procedures, it's important to position the coracoid bone fragment near the 4 o'clock position in right shoulder, but without sticking out to the joint surface. If we consider it as a tendon transfer, it doesn't necessary to have to be placed completely flush with the glenoid surface. And suture anchor placed precisely to complete Bankart repair. Regarding our surgical techniques, most of the patients are large and sometimes huge. Skin incisions typically start 4 cm from the tip of coracoid process. In case where the patient exceeds 140 kg, like a small wrestler, the incision is larger, but it doesn't compromise the screw insertion angle. And even in that cases, the operation takes approximately 2 to 2.5 hours. After coracoid osteotomy, the subscapularis muscles is split bluntly along its muscle fibers and allowing access to the anterior glenoid surface without cut the tendon itself. The glenohumeral ligament attached to the insertion site are preserved during this step, and we then move to the arthroscopy. In arthroscopy, the Bankart lesion is carefully dissected to expose the anterior surface of the glenoid, as indicated by the red arrow in this image. Returning to the open procedure, we re-expose the anterior glenoid surface, and using a 5 cm wide flexible spatula, we inserted it into the joint space to maintain the proper visualization, allowing precise preparation, surface flattening, and coracoid fixation with cannulated screw with washer. Final fixation is done under arthroscopic guidance to confirm the positioning. If the position isn't ideal, we can just redo it. All soft tissue on the coracoid surface is removed to enhance the stability of the Bankart repair site. Even when performing the coracoid transfer, we always repair the bony Bankart lesion. This promotes robust remodeling of glenoid surface. If we can repair the bony Bankart lesion, we can expect the very good remodeling of the joint surface. Do not remove bony fragment, even if we do the coracoid transfer surgery. This case is 28 years old professional boxer with traumatic anterior instability with a bony Bankart lesion. We carried out the bony Bankart repair above the site of coracoid fixation. At 5 months post-operation, CT confirmed complete bone union. The patient returned to the professional boxing match at around 7 months. Another case was 90 years old rugby player with a bony Bankart lesion. After a procedure at 4 months, he achieved full return to play, and complete bone union was confirmed by CT scan at 5 months. We evaluated 212 consecutive cases of traumatic anterior shoulder instability in only collision athletes such as rugby and American football, martial arts, up to 2022. Coracoid union was achieved in 92.5%, with non-union in 75%. All 196 union cases returned to the sport without any recurrences. Among the 16 non-union cases, 2 experienced recurrence. Overall, recurrent occurrence in 0.5% of all 212 collision athletes. Although most non-union cases did not result in recurrence, preventing non-union remained key goal. Conclusion: to success in Bankart Bristow procedure, thoroughly performed arthroscopic bone cut repair. Always attempt bony bone cut repair when indicated. Our Bristow procedure is performed from the outside of the joint, finalized by arthroscopic view. Prioritize achieving bone union in collagen transfer. Thank you very much.
Thank you, Professor Tasaki. To our audience, if you have any questions for any of our speakers, please just type them into the Q&A box and we'll get to them at the end of both lectures. Now we move on to posterior shoulder instability with our second speaker, Dr. Prashant Meshram from India.
Hello, my and why the problem causes a painful. Hello, my name is Dr. Prashant Meshram. I'm a shoulder surgeon from Hyderabad, a city in India, and I'll be talking about posterior shoulder instability and why the problem causes a painful moonwalk. So I'm very glad and honored to represent India on the education committee of APOA HULS. Thank you so much, John and Margaret, for having me on this esteemed panel and also the committee. Thank you. So a little introduction of myself because it's my first time presenting in this particular webinar series. So I was trained in Korea and then I moved on to US to do my fellowship in shoulder surgery for about 2 years, and then I worked with a very esteemed group in Dubai for last 3 years, and since last 1 year I'm back to India working in Hyderabad. I'm also honored to have my academic affiliations, very prestigious journals, clinical orthopedics related research. I'm on the board as well for American Journal of Sports Medicine, and I'm an international member for American Shoulder and Elbow Surgeons. So if you can see here, Michael Jackson is doing his back moonwalk, which is very pleasing to the eye and also looks very smooth. But when posterior shoulder instability happens, the walk kind of becomes jerky like this guy in the center, and it's also a little painful to kind of observe. So we're going to look at why this painful back walk or posterior shoulder instability, what is the pathogenesis, what is the diagnosis, and what exactly are the treatment options. Similar to this young lady who had a fall with the moonwalk, which probably correlates with the posterior dislocation. So in introduction of this topic, the incidence is really 5 to 20% as compared to glenohumeral instability. 5 to 10 years back, probably this was only 1%, but with the advent of MRIs and its extensive use, probably we are diagnosing posterior instability more often. And if you can look at the sports in which these are commonly occur are players of football and baseball and basketball and mostly contact sports, young athletes who have pain because of posterior shoulder instability. In terms of etiology, we can see them traumatically in acute stage. It can also be because of collisions or in contact sports. Seizures and electric shocks do have more propensity of posterior dislocation or instability as compared to anterior. They can also occur without any trauma, especially if someone's participating in contact sports or in multidirectional instability. It can also be in terms of classification, it can either be an acute or chronic, or it can be traumatic versus atraumatic. It can present as a subluxation, which needs to be diagnosed on clinical examination, or a frank dislocation. It could be a voluntary dislocation or subluxation, involuntary, or associated with multidirectional instability. All these are very, very important to classify before we start treating these patients. In terms of pathology, it can either look like this in the picture of capsular stretching on the posterior side or a tear in the labrum. Or it can look like this, which is a posterior glenoid bone loss, or something like a reverse Hill-Sachs lesion, presenting anteriorly at the humeral head, or excessive retroversion. All of these need to be carefully examined and diagnosed on the clinical examination as well as imaging. So moving on to the diagnosis of posterior shoulder instability, bringing back this guy because why not? Posterior shoulder instability most commonly presents as pain, and this is the differentiating factor as compared to anterior shoulder instability. In anterior problems, the dislocation is more common as compared to pain, but in posterior it's exactly different, and this is something to note. They can also present as dislocation, in which it will be more obvious as a deformity, if you can see it here, and they need to be relocated on an emergency basis. More often, these patients also present with weakness, in which their performance during their sports is actually going down and they are wondering why it is happening. And a careful clinical examination is required in order to identify if they do have weakness in flexion and external rotation especially. They can also present with scapular dyskinesia, if you can see on the right side here. And I think this is a very underlying problem which we need to correct. Doesn't matter which type of treatment we are offering to these patients. Special test for posterior shoulder instability includes a posterior drawer test done in a supine position. When you push the shoulder back with your thumb, you will feel that the humeral head is subluxating, and there will be pain which is felt by the patient. Jerk test, which is done either in sitting or standing position, in which with posterior thrust with the patient arm in flexion and internal rotation, it gives you clung or reproduction of the pain. Another test which is very popular for posterior shoulder instability is Kim's test, in which along with the jerk test we also have a lateral push in order to improve the chances of catching subtle instability. Load shift test, in which we hold the arm or the humeral shaft in this particular manner and try to shift the humeral head either front, back, or inferiorly. When you do it inferiorly, it's called as a sulcus sign, which tells us about inferior instability. This helps us to understand what exactly is the direction of the instability. And O'Brien's test, which was initially described for AC joint and slap tears, can also be used for posterior labral tears because it produces pain when you have resisted flexion in internal rotation arm. We should also do a generalized laxity testing with Baton's score, in which there's a score of 9, and these individuals have more propensity to have redislocations, and they need to be managed with different kind of approach, starting with physiotherapy and, if required, surgery. In terms of the sensitivity and specificity of the test, it seems the jerk test and the Kim's test kind of come out on the top when it comes to overall accuracy of detecting posterior shoulder instability. In terms of imaging test, definitely X-rays are the first go-to investigations, in which a true AP X-ray has to be taken. You can see this light bulb sign, which is indicative of posterior dislocation. I also like to do a very good axillary view, especially in cases which are subacute or kind of chronic. In case there is a posterior log dislocation, you will come to know in this glenoid defects, reverse Hill-Sachs defects, and these Bennett lesions, which is a posterior ossification at posterior inferior glenoid rim, can be detected with this particular investigation. X-ray arthrogram is something which can also be done, which actually tells us if there is any rent either in the rotator cuffs or the labrum. This little non-specific but sensitive test in case you don't see anything or find any kind of injury on the MRI. But since the advent of 3 Tesla MRI, which are available extensively, at least in my country, and they're also pretty affordable, we do not need to do an arthrogram. Even an MR arthrogram is not necessary, in my opinion, because it really beautifully shows the labrum tears. It shows the glenoid bone lesions as well as the reverse Hill-Sachs lesions. MRI also helps us to diagnose paralabral cyst, which can come with nerve compression, and this needs to be checked clinically as well as on imaging. In terms of CT scans, as we already know that they're used for quantification of glenoid and Hill-Sachs lesion bone loss, so that we can decide the treatment, whether we want to do an arthroscopic treatment, a bony block treatment, or just a soft tissue procedure. I typically like to get an on-face view of both the glenoids and in the 3D reconstruction, and then measure my bone loss based on best fit circle method. So in terms of treatment, what are the options when it comes to posterior shoulder instability? When they do come at acute stage dislocation, the best thing to do is to get them reduced as soon as possible. I like to use sedation, in which there's a longitudinal traction, internal rotation, as well as lateral traction to disengage the humeral head, external rotation in order to reduce, and finally an immobilization in external rotation, and followed by a physio after 3 weeks of immobilization. So non-operative treatment is indicated when patient is having, they do not come as acute dislocation, but when they come as chronic pain, then patients can have atraumatic posterior instability. They can have traumatic etiology but with subluxations, and a posterior labrum tear without instability or without frank dislocation. Those are the patients in which I would try non-operative treatment of a physiotherapy which is focused on scapula strengthening or scapula stabilization and cuff strengthening, at least for a period of 3 months before I offer them a surgery. In terms of operative treatment, one of the most preferable treatment option is arthroscopic repair of posterior labrum. And in multi-directional instability cases, along with this, we may or may not also choose to have additional rotator interval closure, and this is a little controversial. So in terms of positioning of the patient when I'm doing an arthroscopic posterior labrum repair, I like to have a lateral decubitus position with arm in traction, and I like to have 2 posterolateral portals, which helps me for instrumentation while I'm looking from an anterosuperior viewing portal. So the first step is to identify the tear and then use an elevator in order to raise the flap and make sure that we have a bleeding bone at the time of or at the spot where we want to do the repair. This is followed by insertion of the anchor. I typically like to use a knotless anchor for this particular surgery. I use this kind of lasso loop suture passes in order to pass my threads, and then finally fix them in a knotless fashion. But I think knot and knotless have consistently shown not to have any difference. My preference is just to have a knotless repair. In terms of results, arthroscopic repair of posterior labrum has very good results. 161 overhead athletes in study by Bradley has about 90% of return to sports, and most of the patients have done really well. In terms of systematic review of 396 shoulders, 93% of return to sports, and most of the patients did really well in terms of pain control. What about long-term studies when it comes to arthroscopic repair? Bradley's again study 200 shoulders, 90% satisfied, and 21% actually returned to the same level of sports at a 10 years follow-up. And the people who required a revision were actually associated with glenoid bone loss, probably because of a mistake in the diagnosis at the time of assessment before surgery. Mazoka presented his 10 years paper, 21 patients, 14% only revision, and most of these patients were, they had very, very good outcomes and satisfaction rate. When we see this kind of paralabral cyst, then we need to think of sphenoglenoid notch and decompression, and also suprascapular nerve decompression, and followed by a labrum repair. We also need to assess the bone loss, and this is a rough figure. I'm not sure if the literature has any indication on what is the critical or subcritical bone loss when it comes to posterior shoulder instability, but with a 25% bone loss, I would like to do a bony procedure in the term of either an allograft or autograft iliac crest. In terms of humeral bone loss, most of the patients are okay if we do a McLaughlin procedure. Again, the indications when you do it, when you don't do it, what is the cutoff is really not indicated or not clarified in the literature so far. And in McLaughlin procedure, we just do an subscapularis transfer, if you can see in these images. And when it's massive, about 1/3 of the humeral head is gone. In that case, you can do an osteoarticular allograft. In rehab, after posterior shoulder labral repair, we immobilize them in external rotation brace for about 6 weeks, start them on pendulums and active assisted exercises up to 90 degrees of flexion, then physio up to 3 months, and then they can start gym and return to sports at 6 months. So presenting one of my cases, 21-year-old national basketball champ came after trauma during defense, but there was no dislocation. He tried everything, injections, physio did not help him. And there was weakness in all his movements, and he said that his game is not the same, and he wanted to get out of that situation. So this was actually his clinical picture. He had an anterior as well as the posterior labral tear. He was going out in the front as well as back when it comes to examination under anesthesia. And this was how the repair was done. I mentioned about this, that I do a knotless kind of repair using 2.9 mm anchors. I also do knotted ones recently since moving to India, but this works really well in my hands. This is how the patient is doing after 6 months. He's back to playing basketball at the highest level, and so far he's doing good. And I think one of the main reasons for this kind of success is if you do not miss the posterior labral lesion. So in summary of my talk about posterior shoulder instability is that the diagnosis can be tricky. We need to have an eye on it, especially young athletes who come with pain. There is no frank dislocation. We should give a trial of non-operative treatment of about 3 months. Arthroscopic labral repair does have very good favorable outcomes, and quantifying the bone loss is important in order to avoid failures of a labral repair. Thank you so much for your attention, and thank you again for inviting me to this wonderful webinar as well as the APOA HULS Committee for Education representing India. Thank you very much.
Thank you. Thank you, Dr. Tasaki and Dr. Meshram. I'm Myung-Sun Kim from South Korea, and as the commentator, I will have a Q&A time, starting with the first topic of Dr. Tasaki. Thank you for your excellent presentation on the open Bristow procedure. It was impressive to see how open Bristow technique still plays such a crucial role in managing anterior shoulder instability. Today's lecture you have shared was especially inspiring. My first question is about surgical indications of open Bristow procedure. Given the increasing preference for the Rattaje procedure in many centers, in what specification population do you still prefer the open Bristow technique over Rattaje procedure?
Thank you very much for your question. About the coracoid transfer surgery, I try to leave the CA ligament, coracoaccuminal ligament. If we do a Rattaje procedure, because I have experiences, we have to cut down the all part of the CA ligament. But we do a Bankert repair, maybe a half part of the CA ligament, only cut down to take the coracoid out. So theoretically, we have a benefit of the CA ligament leaving. Also, I consider the coracoid transfer as a tendon transfer, because effect of the coracoid transfer is mainly sling effect. And I do repair the bony Bankert region. So I don't consider the bone fragment as a bone block or augmentation of the joint surface. So very easy to treat using one screw to fix the coracoid onto the anterior aspect of the glenoid. Of course, we have to concern about the non-union rate, because theoretically it would be higher than Rattaje procedure in terms of the coracoid non-union. But so far, we have a moderate result. So in terms of the invasion, we still prefer to do a Bristow procedure rather than a Latage procedure.
Okay, thank you. And the second question is about long-term clinical outcomes. Can you share your experience on the long-term functional outcomes and the potential complications such as hardware irritation or subscapularis dysfunction after Bristow procedure?
Yeah, in terms of the subscapularis, we only split bluntly the muscle area. We don't cut down the tendon area of the subscapularis. So theoretically, we don't have a big invasion to the subscapular itself. And also, if the placement of the coracoid is sticking out to the joint surface, it would be a chance of the osteoarthritis. Therefore, I always look at arthroscopically the position of the coracoid. If it's sticking out, we just redo. Once remove and return to the open surgery and place onto the safer position, then we will check up arthroscopically the location of the coracoid. So, so far, we don't have a big problem of the osteoarthritis. But maybe a 7 year and 10 year is my longest follow-up with the patient. So we will check up about the long-term process. Thank you for asking.
Okay, thank you. The last question is about the surgical technique. From a technical standpoint, when performing the open Bristow procedure, what are the most critical steps or pitfalls that young surgeons should pay attention to?
Of course, try not to invade the muscle tendon when we do open surgery. So location of the incision is from the tip of coracoid down straightly down to the inferiorly. We won't do the pectoralis aligned incision to try to see inside of the joint. So we can access easily to the anterior surface of the graded surface. And also, axial nerve is running just beside, best very close to the in front of the subscapularis. So sometimes we pull using metal device to pull inferiorly the axial nerve. So maybe a temporary problem of the axial nerve. I have experience of 3 cases, 3 months lasting of the partial axial nerve problem, but all cases get recovered. So nerve running area, we have to check through cadaver training. Try not to invade the nerve. That's maybe most important part of the surgery.
Dr. Tasaki, thank you very much for your wonderful lecture. Thank you. And let's move to the second topic of Dr. Meshram. Thank you for your outstanding talk on posterior shoulder instability. Your comprehensive overview from diagnosis to treatment for posterior instability was both practical and insightful. My first question is about diagnosis. Posterior instability is frequently missed or misdiagnosed, especially in traumatic or subtle cases. What clinical or imaging findings do you think most reliable for making an early and accurate diagnosis?
Thank you so much for your question, and I apologize that I'm at the airport, so there may be some disturbances. I'm very happy to join and present our work. So one thing, I agree with you. These are very complex kind of injuries, not in terms of complex, just a labrum tear most of the times or stretching, but in terms of presentation. So a lot of times they are misdiagnosed. They go with their MRIs to multiple hospitals. And when they finally reach someone who understands posterior instability, we have to be in a position as shoulder surgeons or experts in upper limb to be able to diagnose these. So what I do is any young guy who without a dislocation, if he complains of pain, especially when he's being active, it can be it can also happen nowadays because people are being active even if they are not playing sports. So in certain activities such as opening the door or driving their vehicle or swimming, if they have pain in a young patient, I'm already thinking of some kind of labrum tear. I have trained myself over 5 years to look for the posterior tear on the MRIs. When it comes to my, just to answer your question, in terms of physical examination, I think Kim's test is absolutely fantastic. Second thing would be my load shift test. I try to do it in a supine position because the patient is more relaxed that way. I think these two tests for me are very important indicators of posterior labrum. The second test, which I really like, is a 3 Tesla MRI, as I mentioned in my talk. I think it has added advantage over 1.5 Tesla. So I recommend everyone to kind of send your patients, especially these kind of patients. These are very tiny injuries. You don't want to miss them. And if you don't have that, if you have only 1.5 Tesla, because we work in different institutes, you should definitely get an arthrogram, as per my humble opinion. Now, finally, we are treating a lot of patients for anterior instability. And when we put the scope, I always look for posterior instability, even if the MRI did not show it, because these are hidden lesions, just like subscap tears. You go and you look for them. That is the only way you diagnose. Otherwise, you will treat the patient and they for anterior instability, and they still come back with pain. And we are scratching your head like I did everything. You did not look for posterior instability. So that's an excellent question. But those are the tests, and that is the imaging which I rely upon. Finally, diagnostic arthroscopy, I will look for it even in an anterior dislocation case.
Thank you. The second question is about the surgical indication. Considering the variability in the symptom and the structural damages in posterior instability, what are your main criteria when deciding surgical intervention for posterior instability?
So if it's a frank dislocation in a young active individual, I know that the labrum is going to be torn. Anyone who is less than 30 years old, I would be inclined towards doing a surgery in terms of frank posterior dislocation. I think we have data and we have research to back this. We are doing it for anterior instability, but I think posterior instability also, and we also need to understand that how we judge our results, what we call as successful results. It is not just if the patient is dislocating again or not after surgery. It is about taking away that apprehension. I think for me, that is the key, so that he should be able to return to sports with the same level he has. So someone who comes to the frank dislocation typically gets an MRI. And if I find a significant labrum injury, I counsel them for surgery, especially in young active individuals. If someone who's coming with just pain, I always try a physiotherapy for 3 months minimum. You should not try it. I don't think 1 month or 2 months is enough. If their strength improves and they're able to go back to sports, their apprehension is gone, I think you don't need to operate on those. And after 3 months of physiotherapy with a compliant patient, if that is not working, probably that is my candidate for doing a surgery.
Okay, thank you. Time is over. So, Jana, Francesca, would you please close this session?
Yes, thank you very much to our speakers and to Professor Kim for your valuable insights and for just helping us tie together the key learning points from our 2 talks. Please stay on as we move forward onto our next session. We have a couple questions in the Q&A box, but we'll just ask our speakers to type in their answers for that in the interest of time. So we now move on to our hand session to be moderated by Dr. Elaine Law.
Thank you.
Hi. So thank you, Dr. Jana, for the introduction. So in this next session, we will be talking about hand, and with a main focus on PIPJ fracture dislocation. I'm very honored to be part of this panel. And first, we have our special commentator, Dr. Pramono Wibowo. He's an expert in orthopedic trauma and upper limb surgery. He's from Indonesia. So we're very honored to have him here with us. And for our first speaker, Dr. Hiroki Yokoyama from Japan, the young aspiring hand orthopedic surgeon. He's currently doing his graduate program at Nagoya University. He has a special interest in the fracture dislocation of PIP joint. And today he will be talking to us about the acute treatment, the comparison between open reduction internal fixation, volar fixation versus external fixation. So let's hear your talk. Thank you so much, Dr. Hiroki Yokoyama.
Thank you. Can you see the slide?
Yes, thank you.
Okay. Hello everyone, I am Dr. Hiroki Yokoyama from Nagoya University. Today, I will present the results of a multi-center study comparing clinical outcomes between broad plate fixation and dynamic external fixation for dorsal fracture dislocations of the PIP joint. Dorsal fracture dislocations of the PIP joint typically result from axial compression or hyperextension forces. The degree of instability correlates with the extent of articular surface damage at the base of the middle phalanx. Dislocations start to occur when more than 30% is damaged. They become unstable beyond 50%. These injuries are challenging to manage due to joint surface incongruity and instability. Which treatment is best remains controversial. For osteosynthesis, external fixation and ORIF are the options used. Dynamic external fixation is relatively simple and allows early range of motion training while reducing axial load on the joint. However, it carries disadvantages such as pin site infection, joint surface depression after pin removal, and interference with adjacent finger during rehabilitation. Volar plate fixation is becoming more popular. Small fragments can be fixed securely by the buttress effect. Subcondylar support screws can also be inserted when needed. One disadvantage is that the surgical procedure is technically demanding. According to prior reviews, the postoperative PIP joint ROM between dynamic external fixation and ORIF was generally equivalent. However, infection was reported more frequently in the DEF group, while residual dorsal subluxation was more common in the other group. A major limitation was the lack of standardization in surgical techniques. We hypothesized that broad plate fixation might provide superior outcomes because it avoids an external device and enables surgical early rehabilitation. This issue has been partially addressed in several case series, but to investigate the best treatment for this fracture in greater detail, we conducted a multi-center study. We collected cases from 6 hospitals. Patients had undergone surgery with either broad plate or dynamic external fixation. Here are the primary and secondary outcomes. In broad plate fixation, we use vulnar incision. When we want to wide surgical field, the skin flap should be designed in a trapezoidal shape. After opening the S3 pulley, we separate the FDS, and then we can see the fractured fragment attached to the broad plate ligament. To achieve a reduction of the dislocation, we insert an extension block cupping. We fit an autograft or artificial bone in the fracture void. After temporary fixation, we fix the fracture with a plate. Next, we repair the FDS and cover the plate. In external fixation, percutaneous procedure or open reduction procedure are applied, followed by a dynamic external fixation system. Active ROM exercise begins immediately after surgery. passive ROM exercise begin 2 weeks after surgery and intensify later. Extension sprints are used as needed. We found no significant differences in baseline data. Similarly, these fracture characteristics were comparable between the two groups. There was no significant difference in operative time. Surgeon proficiency was also comparable. Radiographic analysis revealed no significant difference in residual dorsal subluxation. However, residual central depression was significantly more common in the DEF group. While DIP-ROM was similar in both groups, the VPF group had significantly better PIP flexion in the early postoperative period. However, this difference disappeared in the late postoperative period. Interestingly, extension at the late postoperative period was better in the DEF group. There were some complications. Flexor tendon adhesion was more frequently observed in the VPF group. We had favorable outcomes with both techniques. This supports what previous case series reported. Although central depression remained more common in the DEF group, Kiff-Haber et al. Have shown that dorsal subluxation must be avoided, but anatomical restoration of the articular surface is not always required if early ROM is initiated. This may explain the equivalent functional outcomes despite the residual depression. The superior early flexion in the VPF group may be due to the absence of external hardware, allowing more intensive early rehabilitation. The better extension in the DEF group may be due to broad soft tissue contracture from the Volar approach and implant placement in the VPF group. However, based on Ishida and Ikuta's evaluation, a 5-degree extension lag is not considered clinically significant. Thus, both techniques can achieve excellent outcomes. Let me share the case of a 16-year-old male who injured his middle finger while playing goalkeeper in a soccer game. He sustained a central fragment fracture that had dislocated beneath the central strip. We treated him with Volar plate fixation. Despite a slight limitation in extension, he achieved 100 degrees of flexion. Just 2 weeks post-operatively, he was able to join a school trip and even go swimming. He has since returned to playing as a goalkeeper. Based on our evidence and experience, this is what we recommend. For dynamic external fixation, suitable for patients for whom fracture reduction can be achieved through a small incision or percutaneously. Patients who are able to wear the DEF device for approximately 4 weeks. For Volar plate fixation, patients who are not appropriate candidates for external fixation, for example, those with dementia. Patients who wish to return to water-related activity or occupations early after surgery. However, both procedures result in good outcome. it is important to use techniques that the surgeon is familiar with. Brow plate fixation allows better early flexion, while dynamic external fixation shows slightly better late extension. However, the 5-degree difference in extension is not clinically significant. Both surgical methods provided favorable clinical outcomes for treating dorsal fracture dislocations of the PIP joint. Thank you very much for your attention. I'm happy to answer any question you have.
Okay, thank you very much, Dr. Hiroki. So next, we will invite our second speaker first, and then we will answer the questions that the audience may have. So for our second speaker, we have Dr. Shilu Shrestha. She's an established orthopedic trauma and hand surgeon from Nepal. She did her clinical fellowship in hand and reconstructive microsurgery in National University Hospital in Singapore. And today we're very honored to have her to talk to us about the delayed presentation of PIP joint fracture dislocation. So welcome, Dr. Shilu.
Thank you so much, Dr. Elaine. I would like to start by thanking the organizing committee, especially Dr. Falk and Dr. Esther, for inviting me as a speaker. I feel very honored and privileged to be one of the speakers. And I would also like to thank my preceding speaker, Dr. Yokoyama, for giving the wonderful talk. So I would... So I'm Dr. Shilu Shrestha. I'm an orthopedic hand surgeon from Kathmandu, Nepal. And I'll be talking about the PIPJ fracture dislocation delayed presentation. So this is the general outline of my presentation to understand the pathoanatomy of the PIPJ fracture dislocation, review the diagnostic pitfalls, discuss the different surgical strategies, and analyze the outcome. So PIPJ is a bicondylar hind joint and has the largest arc of motion, 0 to 120 degrees, and it is responsible for 85% of the total finger motion. So it is quite a stable joint with a box-like configuration, which is well secured 3 sides, dorsally by the center sleeve, laterally by the collateral ligaments, and volarly by the volar plate. So the collateral ligament and the volar plate are the main static constraints. So we can see the accessory collateral ligament gets attached to the volar plate and the flexor sheath, whereas the proper collateral ligament is more on the dorsal side and has a bony attachment on the both sides. Volar plate is a very specialized structure, fibrocartilaginous structure, which is attached on the base of the middle phalanx and attached to the proximal phalanx with the chacron ligament. And we have other center sleeve, flexor tendon, and lateral bands as a dynamic constraint. So there are various spectrum of the injury. It can be a pure dislocation, dorsal, volar, or the lateral, or it can be a fracture dislocation, dorsal or the volar. It can be pilon fracture, or it can be acute and delayed, and it can be open or closed injury. So different mechanism of injury leads to the different spectrum of the injury. Like if there is only PIPJ hyperextension, it leads to the pure dislocation. If it is associated with the axial force, then it leads to the fracture dislocation. And if the axial load is in flexion, it leads to a dorsal fracture dislocation. And if the axial load is in relatively hyperextension position, then it leads to the volar fracture dislocation. And if the volar plate ruptures and get interposed between the proximal and the middle phalanx, then it can lead to the irreducible dislocation. And if there is only axial compression force between the proximal and the middle phalanx being in a co-linear position, then it leads to the pilon fracture. So PIPJ fracture dislocation is one of the very challenging injury, and it has an immense impact on hand function with significant limitation of the digital range of motion. And if it's left untreated or suboptimal management is done, then it leads to the chronic joint instability, pain, stiffness, and the deformity. So Eaton has classified it into 3 different types. Type 1 is a hyperextension injury where there's just a avulsion of the volar plate. And if there is no contact between the articular surface of the middle and the proximal phalanx, then it leads to the type 2 dorsal dislocation. And if it is associated with the fracture, then it becomes type 3, which can be stable or unstable. So if the fracture constitutes only less than 30% of the articular cartilage, then it's usually stable because the collateral is still in the place. 30 to 40% is plus or minus. If it is more than 40% involvement of the articular cartilage, then it's usually unstable because the collateral ligament is with the fracture fragment. So unfortunately, the delayed presentation is not very uncommon in this scenario. And when to say delayed, the 6 weeks of the demarcation for most of the chronic injury, I don't think that holds true for the PIPJ fracture dislocation. So usually most of the people agree that after 3 weeks, we can call it as a delayed presentation. So most of the time, the patient would not seek the medical advice because they think it's just a simple finger strain. And even if they go and present to the clinician, it might be misdiagnosed, especially because the X-ray is done in a suboptimal way. Like in this case, we can see in the X-ray doesn't show any significant finding. But if we do the good, true lateral view X-ray, then we can see there is a fracture and there is a subluxation. So even when the diagnosis is met, sometimes this is overlooked, thinking that it's a very simple fracture. Whereas it causes a lots of challenges, like there is a lots of soft tissue contracture, there is an intra-articular malunion, there is a chondral erosion and the subchondral collapse. The volar fragment might get resolved and it leads to lots of stiffness, and it gives us a lesser surgical option, and no matter what we do, the outcome is might be suboptimal. So clinical evaluation, like in any other case, the most important salient feature to note is the duration and the mechanism of injury, any previous treatment history, and if there is joint instability. On physical examination, the main thing is to look for the deformity. And usually local anesthesia is useful in the early cases. Delayed cases might not need a local anesthesia, but the most important thing is to see the integrity of the collaterals, flexor, and the extensor tendon, both in active and passive range of motion. And definitely neurovascular status is more important in acute cases. So plain X-ray is the main diagnostic tool, and the most important to see the signs of instability is the loss of parallelism and the dorsal V sign. The other things we need to look for is the percentage of the articular surface involvement, articular step, comminution or fragmentation, joint subluxation or dislocation. And sometimes we need to have a traction view, especially to visualize the depressed articular fracture. We can also do the CT scan to see the articular comminution, fragment size, subchondral collapse. So there are various options for the management, but no matter what we do, the main goal of the management is to obtain a concentric reduction of PIP joint to maintain the joint stability and to allow early range of motion. So extension block splint is more important for the early presentation. It's usually indicated for the patient with residual collateral stability without any articular incongruity, and when the reduction can be achieved with less than 30-degree flexion. In this case, we do the splinting with the flexion slightly more than the point of the potential redisplacement, and slowly the finger is brought into extension every week with the serial X-rays, and active flexion exercise is done within the splint. And there are various extension blocking splinting that we can do. And if the patient is not compliant for the splint, or the finger is too short or swollen, then we can do the extension blocking pin, where we pass the K-wire in the head of the proximal phalanx between the central tendon and the lateral band to block the PIP joint extension. So we can use the external fixator as a ligamentotaxis to achieve the joint and the fracture reduction. The main indication being the pilon fracture, and also in a highly comminuted and highly unstable fracture. But and it can also be combined with the other procedures, but we have to understand that it might be cumbersome to wear, and sometimes very difficult to mobilize if the adjacent adjacent digits are swollen, and obviously there is a risk of pin tract infection. So there are various types of external fixator. We can use static or dynamic. There is a commercial made external fixator, or we can make it on our own with the K-wires. So this is a very simple kind of a frame that we can make. And we are very, we use mostly this kind of a Suzuki frame as our external fixator. So open reduction with internal fixation is useful in mostly acute cases with single large fragment. The anatomic restoration of the articular surface is technically very demanding, and there is a high chance of flexor contracture. There are various approaches to do the open reduction and fixation, and various fixation devices, like we can use the screws, we can use the plates, or you can use the insert glass. So basically, I'm more concentrated on the last two salvage procedure, mainly for the delayed presentation. The volar plate arthroplasty, first described by Eatons in 1980. It is used for severe unstable comminuted volar fracture, especially if the volar fragment is less than 40%. It is to resurface the volar lip by excising the volar lip of the middle phalanx with the volar plate advancement into the bony defect using a pull-out wire. So describing the procedure, we can use a standard Brunner zigzag incision centered at the PIP joint crease, or we can also use the trapezoidal type of the incision. And then after the blunt dissection, we need to visualize the neurovascular bundle on both sides and mobilized. Then we cut the A3 pulley between the A2 and A4 pulley as a rectangular flap, and then we can retract the tendon in ulnar or the radial side. And we can incise the volar plate distally and laterally, and also release some collateral and do the hyperextension of the PIP joint to see the joint, also known as shotgunning. Then we need to prepare the joint for the volar plate advancement. We need to create the trough and the base of the middle phalanx. Then we suture the volar plate using a non-absorbable 2O suture in a bundle technique, and then we pass through the base of the middle phalanx to the dorsum, distal to the central slip. And then we do the tensioning so that the volar plate get advanced and have a smooth transition between the volar plate and the remaining articular surface of the base of the middle phalanx. And then after it is reduced, then we make a knot over the dorsum. Sometimes we can do the bone graft on the more distal part of the volar plate if needed, and we might have to pass on the wire to make it more stable sometimes. So we can do the dressing in 2 to 3 days, and immediate passive flexion and exercise can be done, and active flexion can be started in 3 weeks' time, and the extension block wire can be removed in 3 to 6 weeks. So hemihamate reconstruction arthroplasty is usually used for the unstable PIPJ fracture dislocation with more than 50% of the palmar base of the middle phalanx base fracture. It is used as a joint salvage after the failed treatment, and usually if dorsal cortical continuity is there, then it's easier to do the procedure. So we can do the standard Brunner incision or the trapezoidal shape incision. And same like the previous one, we can lift the rectangular flap of the A3 pulley, retract the tendons, and then cut the volar plate proximally, distally, and on the side, release the collateral like that. And then we do the hyperextension of the PIP joint as shotgunning to see the articular joint. It really gives us a very clear view about the joint, and we can debride the fracture fragment here and create a trough for the graft to be placed. And then we go and take the graft from the hamate, making a dorsal transverse incision over the 4th and 5th CMC joint, and then longitudinal incision underneath, trying to not cut the nerve on the dorsal surface. And after we take out the graft, we need to be careful that we should not be damaging the articular surface of the base of the metacarpal, and it should not be too big, causing a CMC joint instability. So after that, the graft is inset into the defect, and it is fixed with 1 to 1.5 millimeter of screws, or 2 to 3 in number. The most important thing is to restore the middle phalanx base geometry. So we can see it needs to be a curve like that and not a straight like that. But it's easier said than done. It's mostly the hit and trial. You take a graft off and then you keep on trimming back and put it on the top. So after that, we need to reattach the volar plate, collateral ligament, and the flexor tendon sheath back in place and close the wound with the PIP joint in a flexed position with the dorsal blocking splint. We can do the dressing in the 3 to 5 days and start the active PIPJ flexion exercise with the extension block splint. And after 3 weeks, if there is a concentric joint reduction with the solid graft fixation, then we can remove the splint and start the gentle active assisted range of motion. And usually there is a flexion contracture with that. So later on, we can do the passive range of motion exercise with dynamic extension splint, which can be discontinued in 8 weeks' time. So these are the few case examples that we have done the hemi-hamate arthroplasty. So when nothing works and even this kind of surgery fails, then we can do the PIP joint fusion, pain being the most common complaint, and usually if it involves the non-dominant hand. It allows faster return to the work and gives minimal rehabilitation, and it's very useful for the patient who cannot do the longer follow-up. There are various surgical techniques that we can use. We can use a plate to fix it. We can use the tension band system, or we can use the headless screws to fix it. So regarding the outcome, there are very few studies which provide the direct comparison between these techniques. There is lack of consensus on the best approach to the treatment, and there is no surgical treatment method which yielded the consistently greater average outcome data to others across the different outcome measures. So there was a systemic review which was published in the Hand Journal, which shows the different surgical outcome with different repair method, and they have kind of tabulated all the outcome for all kinds of papers published for each surgical technique. And finally, they concluded that there is no surgical approach which yielded consistently higher average post-operative outcome. So the treatment requires delicate decision-making that ultimately is based upon the fracture type, area of the affected joint space, and the size of the fracture. So to conclude my talk, it is usually overlooked and dismissed as nothing more than a jammed or sprained finger. PIP joint is prone to stiffness following even just a minor sprain. Therefore, the early diagnosis and treatment is essential to achieve optimal outcome. The treatment requires delicate decision-making based on the fracture type, size, and the area of the affected joint space. Management done within 6 weeks following the injury had a better outcome than the delayed presentation, and some loss of motion is expected in nearly all cases, regardless of the different kinds of treatment that we do. Thank you.
Yes. Dr. Elaine, should I start it or you first?
No, of course. Please start.
Okay. Before I begin, thank you for Dr. Margaret and Dr. Jonathan for having me here. I appreciate the opportunity given to me to join the very insightful webinar. And for Dr. Hiroki Yokoyama and Dr. Shilu Shrestha, I enjoy your presentation, and I'm sure the audience feel the same too. I have a question about Dr. Hiroki. On your presentation, you mentioned about joint surface depression, and you also mentioned about putting bone graft to maybe fill up the bone height. So in acute setting, do you always do treating the joint surface directly, or you will come again in the second surgery? And for the bone graft, will you take the auto bone graft, or you'll just directly do synthetic bone graft? Thank you.
Okay. Sorry. Your question is how to use bone graft?
Yes, in your presentation, you're mentioning putting bone graft to maintain the height of the base P2. So in your practice, do you always use the auto graft or synthetic bone graft? That's the first question.
Okay. Actually, I always Always, not always. I use artificial bone. But some case in other hospital, autograft bone are used.
Okay. Okay. So my second question is, you mentioned about the joint surface depression on the fracture dislocation, PIP fracture dislocation. So, do you treat the joint surface depression at the acute phase, or you will do another surgery?
Another surgery. How to treat?
Yes. So, for the fracture dislocation, usually there is a joint surface depression or missing cartilage from the severe case. So, do you do the reconstruction directly, or you will do it later on the second stage?
Yeah, directly. Yeah.
Thank you. So from your presentation, we can learn that there's no ideal treatment. It depends on the fracture location of the fracture and the extent of the bony injury. Thank you. And for the Dr. Shilu, I have a question. How can you give us tips how to take good bone graft for the hemi-hemate arthroplasty? I see your picture, you're using the K-wire, and we always have difficulty to make the not straight, but a little bit bent.
Yes, I think that's a very good question. Thank you for the question. So it has always been very difficult for me. Every time I also struggle. So I think it's a hit and trial. I think I would take a slightly bigger graft than what is needed, and then I start nibbling and then keep on doing the hit and trial, and finally it will still sit straight. So then I will use some more bone graft on the more distal side, so that I can lift that up, and then but then when you lift that, then it becomes more prominent on the volar side. Then I would trim on the volar side of that graft.
So you will use professional K-wire first and test the flexion extension. If the joint surface is enough, then you can change to the screw, is it?
Yes.
Thank you. So my second question, if we found there is untreated on very severe of the fracture, will you consider the use joint replacement arthroplasty instead of the fusion?
So we don't have the joint replacement option here readily available. If I have to do somebody, then I have to get it from India. So, and most of the patient is not affordable. So it's mainly the arthrodesis.
Okay. Okay. Thank you. Thank you very much. From your lecture, we can learn that early identification is very important so that the patient don't fall to the chronic case. So thank you, Dr. Hiroyuki and Dr. Silo, your presentation. Dr. Elaine, come back to you. Thank you.
Okay, I'd like to thank Dr. Pramono and our two speakers for this very insightful discussion. I think we're running a little bit over time. So if anyone has any more questions, feel free to leave that in our Q&A section. And I'm sure one of us will be able to answer that later. And right now, I would like to pass it on to the next section, which we will be talking about elbow. And the next moderator is Dr. Dong Hao Tun from Singapore. So let's welcome them. Thank you.
Hello, everyone. We have come to the last and the final session of today on elbow. I'm Dong Hao. I'm from Singapore, and I'm very honored to have with me Ken, who will be moderating and commenting on our session. Ken, of course, is a good friend of mine. He's also from Singapore. He's a very prominent surgeon in the country, having trained with Badi Savo as well as La Force from France. So he'll be comment on our speakers. So we have two prestigious speakers with us. The first is Professor Anur Bashri from Turkey. If I'm not wrong, he is from Dokuz Ayu University, one of the biggest university in Turkey. He's a very experienced surgeon with more than 800 surgeries done every year. And he's also completed his orthopedic residency at Marmara University previously. He's currently a visiting fellow at the University of Iowa in 2010. And now he is a board member of the Turkish Orthopaedics and Traumatology Council and a faculty member of the ESCA as well. Without further ado, let's introduce Dr. Anur. Dr. Anur, please. Dr. Anur, you can start your talk. Sorry, Dr. Anur, are you muted? No, we cannot hear you, Dr. Anur. Ken, can you hear? Is there a problem with my system?
Can you hear me?
Yes, yeah. I can hear you now.
Oh no, I can hear you now. Thanks. Hey Ken. Sorry for the problem. No problem, man. Carry on. Okay, I shade it back. All right. Good evening, everyone. Sorry for the delay. First of all, I'd like to thank the upper hand and upper limb section and my dear friend Ken for the kind invitation. It's a pleasure to be here with you today. Today, I'll be sharing a practical overview of the traumatic elbow instabilities, how we diagnose it, classify the injury patterns, and choose the right things for us. I have nothing to disclose. So there are 4 essential principles. First, understand the injury mechanism. Radiologic assessment is the key, so always follow the imaging clues. Second, know your surgical anatomy to choose the best approach. Third, fix or replace only what's needed, practicing an a la carte surgery and checking joint stability after every step. Finally, remember a stable joint is critical for early mobilization and better recovery. Although elbow instability can seem complex, we can group most traumatic cases into 5 patterns. 3 involve through dislocations, including the treble triad, while the last 2, transverse Pramono and the Montague injuries, are fracture patterns that destabilize the elbow and are managed as dislocation variants. Want to talk about the collateral ligaments when we talk about this pretty good diagram of what the dislocation versus disruption is. In dislocation, the joint surfaces are separated or not, They're not congruent, but in the disruption, those joint surfaces typically are still aligned, and the collateral ligaments attach to the fragments of the bone. So this helps you in understanding how to treat them. Typically, fixing the fracture fragments in a disruption is going to provide the stability. Whereas in a dislocation injury, so you're going to be requiring some ligament assessment also. In fracture-associated elbow instabilities can be grouped into two main categories. On the left, we see the dislocation-based injuries from radial head or coronary fractures to the classical tribal triad. In the center are the disruption injuries like the transolar coronary fracture dislocations with anterior or posterior displacement. On the right, varus posteromedial rotatory instability stands out, often subtle but critical to recognize due to its unique mechanism and treatment approach. Elbow instability usually results from ligament or radial head injuries. A large coronary fracture, about 50 to 60%, can cause axial and varus instability. Just 30% of the coronary can trigger posterolateral rotatory instability. In complex cases, it's critical to detect and repair K bone and ligament stabilizers to restore stability and allow early range of motion. The classic PLRI mechanism described by O'Driscoll starts with the axial compression and valgus stress in an extended elbow, just like this wrestler, causing LUCL rupture and posterolateral subluxation. The injury can progress to involve the capsule and MCL, eventually leading to complete dislocation. The Schreiber Group 2013 video analysis confirmed this, showing dislocation occurs in extension with forearm pronation and valgus load from inward body rotation. This analysis study shows that elbow dislocation usually starts with a valgus force that tears the MCL. As the deforming torque continues, it leads to LUCL injury. Understanding this sequence helps us predict injury patterns and guide surgical repair, especially in athletes exposed to valgus loading. This MRI study of the same group shows that complete ligament injuries after elbow dislocation are much more common in the medial side, particularly the MCL. On the lateral side, ligaments like the LUCL are often only elongated or partially torn. This highlights the need to carefully assess and often repair the medial stabilizers to restore elbow stability. This algorithm guides repair decisions after posterolateral dislocation. We assess medial and lateral stability separately with valgus stress and range of motion tests, then decide on our ulnar, lateral, and combined repairs based on the results. The easiest way to understand varus posteromedial instability is by using a sawbone model. It's a rotational instability where the forearm rotates internally, causing the LCL rupture. Then the posterior MCL bundle is often suddenly injured. On the posteromedial view, and you see the anteromedial coronary fracture in the sawbone model. It's actually essential to have an PMRI. In posteromedial dislocation, we first repair the LUCL and extensors, then reassess stability. If instability persists during motion, we add UCL and flexor repair if stable. We limit the repair to the ulnar side. The Lanzeret and colleagues used this high-speed video to study elbow fracture mechanics. They observed an initial valgus moment causing the humerus to shift medially, first fracturing and bursting the radial head, with the lateral side bursting and contributing to LCL rupture. The humerus then moved medially, fracturing the coronary. While these are experimental findings, they offer valuable insight though. Please focus on the lateral ligament complex at its humeral origin. You can see very impressed with how it tears. It goes laterally and it's torn and it's going to be going to the other side. So what happens when coronary fracture is over 50%? 50% of coronary is fractured, elbow loses its anterior buttress, leading to severe instability. The coronary is critical for resisting axial, varus, and valgus forces. Without it, the elbow can subluxate or dislocate even under minimal load. This study actually from Rio in 2021 They identified three distinct patterns: PLER, PMER, and PMIR. So the 72% of these are posterolateral, but the posteromedial is in two concepts, which really differ with small differences from the fracture lines in the anteromedial facet. In PLI, typically involves radial head fractures, LUCL tears, and coronary tip fractures. In contrast, PMRI is associated with anteromedial coronary fractures. The initial workup includes standard AP lateral X-rays and CT available. Always examine the risk for axial wrist injuries. After reduction, check elbow stability and extension, because elbow's least favorite position is the extension with also supination. Conservative management is possible in simple, stable dislocation with concentric reduction, stable range of motion, and minimally displaced radial head or coronary type 1-2 fractures. This prospective study shows that if patients meet conservative criteria, they can achieve good functional outcomes even in terrible triad injuries. This one focuses on the concentric joint reduction, an unblocking radial head fracture, a small coronary fragment, and at least 30 degrees of stable motion within 10 days. These criteria are essential for considering non-operative treatment. We typically start laterally if we want to do a surgery, exposing from outside to inside, LCL radial head coronary, and the repair inside to out. Some authors also describe using a single extended posterior approach. This slide shows the two main lateral approaches. On the left, the Coker approach uses the interval between the anconeus and ECU, commonly for radial head and lateral ligament access. On the right, the Kaplan, it really avoids the lateral collateral ligament. Choosing the right interval is the key, balancing the exposure with soft tissue preservation. On the left, for the medials, we have the posteromedial coronate or FCU split approach, where we split the flexor carpi ulnaris at its ulnar insertion to reach the posteromedial coronate and anteromedial facet. This is especially useful for anteromedial coronate fractures and various posteromedial instability. On the right is the Hodgkin's over the top. It's using the most anterior approach for this. So if the radial head is fractured and you're already working laterally, you can often address the coronate from the lateral window, avoiding a second medial incision here. Here on the left, we see the lateral approach showing the typical fascial tear. On the right, we have a complete LCL, avulsion often described as the bare lateral epicondyle. So should we fix coronate, all the coronates? Coronate fixation is a key point of debate. As we watched previously, if more than 50% is fractured, elbow becomes unstable. Fixation is crucial because MCL and anterior capsule insert here, both essential for elbow stability. Type 3 coronate-based fractures should always be fixed. For smaller fractures, fixation is needed only if there is persistent instability after radial head reconstruction and lateral capsular ligamentous reconstruction. This approach ensures adequate elbow stability. If the radial head can't be preserved, we use a lateral approach and excise the radial head to access the coronate. For type 1-2 fractures, we use suture anchors or posterior anterior bone tunnels, while type 3 fractures are fixed with cannulated screws. This study shows that transverse suture fixation offers the lowest rate of dislocation or subluxation when fixing the coronate in elbow fracture dislocations. When preserving the radial head, we usually avoid fixing Regamori type 1-2. However, type 3 fractures require medial approach, coronary fixation, and medial capsular ligament repair, also checking for a humeral avulsion of the UCL. When fixing the radial head, fixation is preferred if possible, with compression screws is the goal. Replacement can offer better range of motion and stability, but raises concerns about long-term outcomes, especially in younger patients. Resection should be avoided, whether using ORIF or arthroplasty. The key goal is restoring the Hoover radial column. Be cautious with the arthroplasty to avoid residual instability or overstuffing, and always check the risk for axial pressing. What about X-fix? If the elbow remains unstable, you will be needing it. So it is better if it's dynamic. So transarticular ulnar-humeral pinning is never recommended. What about infix? Internal joint stabilizer offers excellent dynamic stability, avoids external fixator complications, and allows early range of motion. However, it's technically demanding, requires a second surgery for removal, carries a risk of ulnar nerve irritation, and possibility of hard-grade failure sometimes. So there are some cases here. This is a 42-year-old male with PLRI after push. We expect here LUCL, and after repairing, we should assess the UCL for further intervention if it's needed. Here are the and after LUCL repair, the patient had persistent valgus instability, so indicating the UCL, we proceeded with medial repair to restore full elbow stability here. Pretty good result. So this is 37-year-old with PMRI. We expect LUCL injury, UCL anterior band avulsion, and possibility of the posterior MCL involvement. Careful intraoperative assessment is key for stability. Here you see the lateral exposure and the LUCL repair, restoring the posterolateral stability. Despite the LUCL repair, the patient showed persistent valgus on fluoroscopy, indicating the need to address the medial side, typically the UCL or medial capsular ligamentous structures. After repairing the UCL, the elbow achieved stable valgus alignment, confirmed intraoperatively and on postoperative X-rays. This is 32-year-old male with PMRI showing classic LUCL avulsion, the osmocollateral osteochondral fragment, plus UCL intermediate facet avulsion with MCL posterior bundle injury. The intraoperative, we confirmed valgus and posterior medial instability on the fluoroscopy, and we visualized the LUCL avulsion and UCL involvement, preparing the site for ligament repair. Here is the unstable fluoroscopy images. So the fluoroscopy confirms persistent valgus instability after LUCL. Then, so we fixed that also the post-ops for these for this case. Here's a terrible triad with LUCL again, radial head fracture and type 1 coronoid, LUCL repair with anchors and transosseous coronoid sutures. This is a 50-year-old female with high energy trauma, BADO type 2, Jupiter 2D Montague fracture. Note the radial head, proximal ulna, and the coronoid involvement. Here you see the intraoperative view of radial head arthroplasty and ulnar fixation, and the post-op X-rays confirming stable reconstruction here. So post-op immobilization with hinge brace in 90 degrees flexion, forearm in neutral and slight pronation, early range of motion in the first week, and limit extension gradually starting from 30, and weight bearing, no lifting for 1 kilogram for 6 weeks. Avoid pushing or axial loading, and we also check for the heterotopic ossification periodically. So my last words are always understand the injury mechanism, know your anatomy, repair or replace only what's needed, and check stability step by step. Remember, a stable joint is the key for early mobilization. So as the Vice President of the Turkish Society of Shoulder and Elbow Surgery and co-chair of the Congress, I warmly invite all you to join us in Adana. We promise you an exceptional program with outstanding invited speakers. We look forward to welcome you all. Thank you.
Thank you, Dr. Honor. That was a very comprehensive talk with some very interesting cases and some very nicely taken videos and pictures. We'll try to make it to the conference next year in Turkey. Right, so without further ado, let's move on to the next speaker. So we have with us Dr. Iman Widya, who's currently a surgeon in the Department of Orthopaedics at Fatmawati National General Hospital. So he'll be talking to us on the topic of chronic shoulder dislocation. Dr. Imad, please.
Yes, thank you, Dr. Hao. Good evening, everybody. I would like to send my best gratitude to APOA. Thank you for inviting me. So today I would like to share our experience dealing with the chronic elbow dislocation, which is a condition very common in Indonesia. So let me share my slide. Okay. So again, so chronic elbow dislocation is a condition which is very common we see in our daily practice in Indonesia, because most of our cultural habit in Indonesia, our people usually come to the bone setter, traditional bone setter, before coming to the healthcare facility. And because of this, we will have a problem in chronic elbow dislocation, which is a soft tissue contracture, bony ankylosing, cartilage damage, and neurovascular tethering. Additional limitation in dealing this problem is most of this case coming from the low-income family. And even though we have on our national health insurance, the budget is very limited. And implant or prosthesis is not readily available throughout our huge country, Indonesia. So I've been doing a shoulder elbow for 14 years, and we developed what we call the Fatmawati ways in treating chronic elbow dislocation. And the first thing we need to do is we need to set a goal between patient and surgeon. We have to match the expectation. And then we have to explain the patient that we will need maybe not only single, but also multiple stages of operation. For the approach, mostly we can do with the standard 4 approach, but my favorite is 2 approach, which is the posterior approach, especially if the patient come with the extended stiffness is extend position. And I will do a double medial and lateral approach if I have a patient where the elbow can be flexed for up to 90-degree flexion. And because of doing double medial and lateral approach, I can adequately expose the anterior and posterior side of the elbow while preserving tricep muscle. Works to be done. First, in the soft tissue, we will definitely need to decompress the ulnar nerve, because it's usually there's a fibrous tissue constricting the ulnar nerve. And most of our case, we need to do anterior transposition of the ulnar nerve. Then we proceed to release the scar collateral ligament and then clean the intra-articular fibrosis tissue. And for the bony work, we have to reshape again the normal fossa in the distal humerus, which is most of the case they are filled with the fibrous tissue or even a callus formation. If we face the malunion of the radial head, we can do a radial head excision or replacement. For muscle work, we need to release the brachialis muscle at the front side of the elbow up to the superior part attachment to the anterior side of the humerus. And we also need to release the tricep adhesion from the posterior humerus. And we also need sometimes lengthen the tricep, because in contracted or neglected case elbow dislocation, the tricep is really tight. So my go-to procedure is I do usually a pie crusting technique, which is I remove some part of the fascial tissue and also the tight fascial band, especially in the medial head of the tricep. With this technique, I still able to conserve the muscle fiber of the tricep, and I still have a dynamic stabilizer of the elbow after reduction. In the articular surface, we need to pay attention on the cartilage condition. If it is too heavily damaged, we need to do arthroplasty. But my case, we have a patient which is too young and hard labor and no money. So replacement arthroplasty is not an option. So we go for interpositional arthroplasty. Then after we did a good reduction, we come to this problem. So because of we release all the soft tissue to regain reduction, we will face with the residual instability. If we put our patient back to the prolonged immobilization, then we will have a recurrent elbow stiffness. So what we will do? In the past, I will do a box loop ligament reconstruction of the elbow. We are using the hamstring tendon to reconstruct medial and lateral collateral ligaments simultaneously. This is a case example, patient with 4 years after elbow dislocation. I come to our hospital and we do a standard open reduction and then immobilize in the spleen. And this is the result after we take an X-ray in the ward. Then we see that the elbow is dislocated even in a cast. So it's really unstable. And then we decided to go for the second procedure, which is a ligament reconstruction. We use a box loop technique using a hamstring tendon, autograft, because allograft is not available. We use a gracilis osteotomy, and we make a humeral and tunnel from the lateral epicondyle to the medial epicondyle, and also the ulnar tunnel, mimicking the normal anatomy of the medial and collateral ligament. We fix the hamstring tendon, the graft tendon in elbow 70 to 90 degree flexion and neutral supination pronation. And this is the follow-up, 3 months. He can gain a quite stable elbow and reasonable range of motion. So we published our series in Journal of Clinical Orthopedic Trauma that our patient with chronic elbow dislocation, we did a box loop technique for ligament reconstruction, and we found out that there is an improvement in range of motion, and the Mayo elbow performance score are significantly improved from poor to good. However, we are facing a disadvantages using this technique. In ligament reconstruction, it is a lengthy procedure, and it is cause donor site morbidity, and also it's a complex procedure. And what about if we choose external fixator? External fixator also have a problem, which is difficult to use in elbow, especially hinge external fixator. It is expensive, and of course, it is inherent risk of infection. Patient also cannot well tolerate with the sticking out the sun screw in their upper extremity, and this also will cause a patient want to remove the external fixation before it is scheduled. So what about we use the external fixator? Internal fixator is introduced by Dr. George Orbe from Miami, Florida. It is a device that can maintain concentric reduction while allowing early range of motion and rehab. But again, Indonesia is not available, so we use a modified T-plate to mimic the IGS. So this is how we do it. We do the same procedure as before, posterior approach, release the elbow, anterior transpose the ulnar nerve, and after we have a good reduction, and we will need to find the center of rotation. This is very crucial. You take an a C-arm on the true lateral view, and you find the center of rotation in the epicondyle, lateral epicondyle, mark it, and make a transhumeral drilling. And then after that, we bend the T-plate and fix the T-plate to the distal humerus and the proximal ulna. Then we check again under image intensifier the range of motion and the stability of the elbow, particularly in extension, because elbow is unstable in extension. So we can see that the elbow is quite stable. There is no gapping on the ulnotrochlear a gap, and then we decide this is a good, stable enough elbow. And this is the clinical pictures. And you can see here, the elbow is stable with the T plate. So we are reporting our case series. We did 12 cases for the past January to December 2024, all with posterior elbow dislocation or fracture dislocation, with all in a chronic condition, which is come to the our hospital more than 3 months after the injury. So we evaluate the pre-op and post-op range of motion, flexion extension, also pronation and supination, and clinical function using a Mayo Elbow Performance Score. And we found that the Mayo Elbow Performance Score significantly improved from 45 to 80, which is good. And the flexion extension from 21 to 88, and pronation supination from 51 degree to 127 degree. Which is quite good. And we have one complication in this series, which is an infection, and it causes loosening, which we need to remove the IGS, modified IGS. If we compare our result with the other surgeon result around the world using original IGS, so we can see that the result in MEPS also almost the same, equal, and the range of motion also almost the same, even though we have slightly less in flexion extension. And this is because our series is more, all of them are in a chronic condition, chronic fracture elbow dislocation. Other author in this series, if you can see the original article, there are only few of them are using IGS for chronic elbow dislocation. So this is a case example, 29-year-old female, 1 year after dislocation. See that there's already some callus formation. Patient come with a stiff elbow in 40-degree flexion extension, no movement at all. So we did our open reduction and putting IGS. You can see here, this is a post-op 3 months. You can see that he has a reasonable elbow flexion extension and quite good flexion, supination and pronation. Another case is a female 9 months after dislocation. You can see here's a simple dislocation if come early, but when he come late, it become a very difficult situation. And we did the open reduction, putting internal joint fixator. You can see in this patient, she regained almost full flexion and extension. However, still a limitation in pronation and supination, particularly in supination. This is because the radial head is impinged to the T plate. Another case is 53-year-old female, 7 months after coronary cerebral triad. So we put the IGS on her elbow, and pre-op you can see that her range of motion is less than 90 degree, and this is the clinical picture after we remove the IGS. So you can see that very good flexion and extension, and also pronation and supination. Last case is a female, 58 female, 7 months cerebral triad, male, and this is, you can see that he also get a very good result. There are pitfalls, of course, using this technique, that it is very difficult to have a correct center of rotation. So you need a good lateral view when you make a marking on the lateral epicapitulum, and it will be difficult if you have a posterior capitulum bone loss when you have a fracture dislocation. A screw placement on the ulnar side also must be centered. Otherwise, if you put it too radially or too ulnarly, the the olecranon or the ulna will tilt, and this is also can create instability or even create pain when patient move the elbow. Of course, in neglected case, some cartilage are already worn out, so you cannot expect he or she regain full of motion. And remember, T-plate is a stiff metal. It cannot accommodate the normal varus valgus moment while elbow flexion extension. And the fifth, radial head may be impinged by the plate. So you can have a patient unable to supinate a forearm, but it will be improved after we remove the IGS. And if there is no radial head, it is also medially unstable. It's not only lateral, it's also medially unstable. So you can see here, if we have a medial or radial head also fracture, and you don't put any prosthesis there, even though we put a IGS and we extend the elbow, you can see that the medial ulnohumeral joint is open. And in this case, there are actually two options. You put a prosthesis on the lateral side as a buttress, or in my series, we just put temporary K-wire fixation for 3 weeks and remove it in outpatient clinic, as soon as this example. So in summary, T-plate is as a modified IGS is an alternative solution for managing elbow instability, especially chronic elbow fracture dislocation. It allows early elbow room exercise. However, correct placement of the screw is paramount and temporary K-wire fixation may be needed. Thank you.
Thanks, Iman. Thanks, Honor, for your fantastic presentations and also really great videos. I got a question for Honor. It's from the audience. I think Dr. Stuart Proper wants to know that with elbow dislocations, who should be doing the reduction and under what level of sedation with which investigations?
From the startup?
Yeah, from the start, I guess.
All right. So first of all, we always see an X-ray, of course, and after the X-ray, we actually have a figure what we have in our hands. So we go for a CT scan. Pretty much all the cases we go to for a CT and the 3D reconstruction for those. After that point, you actually start doing the surgery. I mean, you're not in the OR, but your head starts to work on it. So you already see what you have in your hands, and you already have what are you going to be fixing. But of course, after you go to the OR, you have that. You need your fluoroscopy always in the OR. That's for sure. Not only for sending the screws, but also checking the stability after you repair. Because sometimes it doesn't really happen. You do the lateral, you do the medial, it's still not stable. So it sometimes happens. So you have to go back and think what you missed. So that should be a problem, definitely. So what we always do is we go with an X-ray and the CT, 3D. Never go with the MRI. But we have a trauma planner in our PACS system. So we always put our 3D scans into that planner, and we actually do the surgery in front of the computer, first of all.
Thanks, man. Iman, yeah, we heard your excellent presentation. Same in Singapore, we don't have access to the IJS. Although I think our license will be at risk if I try and put a T-plate as an IJS on my side. For your box loop reconstruction, if I don't put that, if I don't put IJS like fixator inside, how long do I need to keep the patient in the cast?
Yeah, thank you, Ken. So yes, if I use a box loop reconstruction, I usually put my patient in the cast for 3 weeks, 3 to 4 weeks, 3 to 4 weeks. I prefer my patient a bit stiff because of the immobilization, but I think I can work out with the stiffness with the good rehab rather than I have a recurrent instability. So usually I put my patient 3 to 4 weeks in immobilization, and then start to mobilize inflection, first inflection. So I avoid asking my patient to extend her or his elbow. Then I will gradually improve elbow extension position after 6 to 8 weeks.
Any tips if I need to revise a failed box loop?
Well, yes, that's a very, very tricky question. Yeah, I have some patient that the box loop is loosening or the tendon is torn. So I do a lot of thing, which is I put another bigger graft and I put additional, how can I say, like putting a suture tape on the lateral side to prevent varus deformation. So that's how I do. But frankly speaking, they are not a very good result. So I still don't have any good solution for that.
Yeah. Okay. There's a question from the audience. I guess it'll be for both of you guys. What's your choice for heterotopic ossification prophylaxis? I guess the audience wants to know choice of drug and duration. Oh no?
Well, we don't routinely actually use a prophylaxis for all cases. Maybe in high risk situations such as in high energy terrible triads, delayed surgery, or extensive soft tissue dissection, or in high energy traumas. We consider a short period of non-steroid anti-inflammatory. It might be indomethacin for 7 to 10 days, 75 milligrams of it with the slow sustained release version, which I'm not really sure it's going to be helping. But if something happens, it always happens. It never helps doing it. So we just if the patient has a risk or prior history of HO, we may think to consultate with the radiation group. So if they want to do something for that. So other than that, we don't really do routinely. And I feel Iman doesn't also. He was just shaking the head.
Yeah, I agree with Onur. I don't know why, but I would like to share my experience. For 14 years, I'm doing shoulder elbow. Not many cases, even though there's a big trauma in elbow in Asia, in our population. I don't know whether it's a race differential, but our people do not tend to have a HO easily. So usually I just use a NSAID, like Celebrex or any kind of NSAID, and allow them to move the elbow active assisted. I never allowed passive motion. So I encourage patients to do early active assisted motion. And I don't have many HO cases. HO may be developed in medial side when you have a MCL torn, but I'm not sure whether it's a really HO or it is a calcification of after the ligament was torn. So if I think the same as Honor, if the patient come with the HO, then after a section I will do radiation. So that's what I do.
Okay, that was great discussion, guys. Fantastic work. Thanks a lot. I've learned a lot myself from you guys. We have come to the end of our session. In fact, we're running slightly behind time, I think. If anyone has any further questions, feel free to write in to our panels. I'll hand the session back to our host. Thank you very much.
Thank you. Good to see you again.
Good to see you, Ono. Good to see you, Iman.
Thank you.
Okay, thank you, everyone. I'm Jonathan Roquillo from the Philippines. Do you have anything else to add, Margaret? If we have nothing else to say, I'd like to close this session, and I would like to thank everyone. Thank you all to all the participants, as well as especially our moderators, commentators, and thank you for helping us make this a successful webinar. We just had just a quick summary of this instability, more common instability problems of the upper extremity, which includes updates, recent procedures and modifications, as well as being resourceful, as Iman has shown. And we hope to see you again soon for our next webinar. We'll be talking about more likely fractures of the upper extremities. And we will be having future activities as well. In February, we'll have a workshop on the elbow in Singapore, as well as a pre-Congress cadaveric workshop with hand surgeries, procedures in India. This will be in the APOA. And we hope to see you again soon. And again, thank you very much and have a nice weekend. Hope to see you all in our next activity. Thank you very much.
Thank you.
Thank you.
Thank you.
Thank you. Bye-bye.
Thank you, everyone.
Please don't forget to fill up the post-webinar survey as well. Thank you.
Recording stopped.